इसको सिलेक्ट करना पहले से फर्स्ट से ना ये चेक नहीं हो लगे इसमें फोटो चलिए फिर बंद करो ओके छोटा Hello, Dr. Swati is stuck up somewhere in the hospital, so let's start. She'll join. Before we start the meeting, I would like to give information that mother of Dr. Ashok Sharma uh, just had a demise today itself. So I would like to request Ashok Sharma is our member who is in Apollo Hospital. So her mother actually expired today, Dr. Ashok Sharma's mother. So I just want to have one minute silence for her soul to start the meeting. Thank you. So now we start the meeting. Thank you. So today we have two cases lined up, interesting cases lined up, and first case will be delivered by Dr. Jay Patel, who is a resident in general medicine at Santosh Medical College. To moderate session, we have Dr. Ashok Kumar, who is always there with us in all the tough times. And to chair the session, we have Raj Gupta, who is a senior consultant neurologist at Max Prakash, and Dr. Subhat Lakshmi. She has accepted my kind request to come to leave his medical college and come here to join the chair. So I think we can request both of you to please come down in the first row. And it's a very interesting case of paraparesis, and I think this paraparesis has been there. We all know that in our general medicine times we used to get this long case of neurology, right? So it's always interesting to have such cases in a forum, and sometimes something rare or something very common comes out. So I think to deliberate more on this issue, I request Dr. Jay Patel, who is the resident of the Department of Medicine, to have the case, and we'll have discussion with our chairs when he finishes off. Thank you.
Good afternoon, respected consultant, and good afternoon, respected consultant. I am Dr. Jay, a resident of General Medicine, Santosh Medical College and Hospital, Ghaziabad. I am presenting a case of paraparesis. 20-year-old. इसका लाइन नहीं इसको लाइन So I am presenting a case of paraparesis, 20-year-old female, presented with chief complaints of high-grade fever since 10 days, vomiting since 10 days, and loose stools since 9 days, and sudden onset lower limb weakness and pain since 1 day. So fever, which was sudden in onset, intermittent in nature, and the highest documented 102 degree Fahrenheit, and associated with chills, relieved on taking antibiotic medicine. Vomiting, which was sudden onset, 4 to 5 episodes per day, last for 2 days, and which was yellowish, watery, non-projectile, non-foul smelling, contains food particles, approximately 100 ml each episode, and not blood stain, no aggravating or relieving factors. And low stool, which was sudden onset, 2 to 3 episodes per day, watery, approximately 200 to 300 ml each episode, yellowish, not blood stained, foul smelling, and no aggravating or relieving factors. Now, lower limb weakness and pain. So, after this, fever, vomiting, and loose stool resolved after 3 days of admission. And now, on 10th day of illness, patient went to washroom and not able to get up from sitting position and walk on her own and kept lying on her bed. Patient developed sudden onset bilateral lower limb pain below knees, which was perceived as a heaviness of both lower limb and was associated with high-grade fever. And patient was unable to bear weight. Both the limbs affected at the same time, which started with feet and later within a 1 hour progressed towards thighs. Bilateral lower limb pain and weakness persisted, for which she was taken some injection from local practitioner, but the symptoms couldn't resolve. So patient was presented to Santos Hospital on 12th of March. So negative history, there is no history of bladder or bowel incontinence, retention of urine or feces, no history of upper limb involvement, no history of backache and headache, no history of breathing difficulty, was able to change position while lying down to either side, no history of diurnal variation, no history of loss of consciousness, seizure, ENT bleed, head or back trauma, no history of lifting heavy objects. But past history of abdominal ma'am, because I am thinking about if patient had got a trauma and after trauma she got either loss of consciousness, bleed, or seizure. So that's why I've taken in the negative history that no, ma'am, patient no history of trauma. Ma'am, past history of abdominal couch 1.5 years ago, for which ATT was taken for 6 months and stopped her own. There is no other significant past history. So, in summary, the 20-year-old female previously treated as an abdominal couch present with sudden onset of high-grade fever, vomiting, loose stool, starting on 3rd of March. So, symptoms was started on 3rd of March, and on the same day, not same day, sorry, or after 10 days of this illness, patient developed bilateral lower limb weakness, which was sudden onset and with severe pain below the knees, which was progressively worsened. And so the symptoms was not got relieved, and the patient presented on 12th of March to our hospital. So by history, just we have gone through differential diagnosis on the basis of history was made of that. Yes. No, sir. You said that yes, sir, actually the fever was started on 3rd of March. And sir, after that, after 3 days, the fever, vomiting, and loose stool was resolved. Then intermittent. But sir, in between, what happens on 3rd of March when the patient got fever first time fever spike. After that, in between, there is a no fever spike. But on the day of illness, means on the 13th of March, sir, patient had a fever with sudden onset of bilateral weakness. The second episode happened with bilateral overlapping weakness. Yes, ma'am. Yes, ma'am. Yes, ma'am. It is symptomatic and then fever with sudden onset of G, ma'am. Yes, ma'am. Again. Ma'am, 3 days. All the three symptoms initially. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, only one spike. One spike of fever. Single day fever spikes. So differentials on the basis of history, we have made hypokalemic periodic paralysis because patient had a loose stool. So I'm thinking about there is a low potassium and patient undergone might be a hypokalemic periodic paralysis. Second thinking is a Guerin-Barré syndrome because I'm thinking about acute onset of ascending paralysis, which can result in bilateral lower limb weakness and painless progression over days. But in this patient is having a sir, I am localizing a lesion so below D10 or D12 vertebrae.
Spinal cord.
Yes, sir.
What are the features which are in favor of spinal cord?
Sir, first thing, there is a sudden onset of bilateral lower limb weakness. Second, sir, there is a
Was there any bladder involvement?
no, sir. There is a no bladder involvement. It is spared.
Was there any history of bad lights?
No, sir.
Any sensory level on history?
Sir, sensory loss is there below.
On the history.
On history.
No, on the no, sir. Sir, severe pain, sir, in back calf muscle, sir. Yes, sir. History, yes, sir.
If it is such a severe pain, it's unlikely to be GBS. You don't get that kind of a pain in GBS.
GBS, sir.
That's why it is happened because we cannot keep one by one.
No,
And
my point was,
hypokalemic also.
are you looking at a UFL
Hypokalemic periodic paralysis, we had a question 1 week
When?
back before the onset of illness.
Yes.
Between 7 days, he was okay. She was okay.
Ma'am?
She was asymptomatic for 7 days, in between.
Yes, ma'am. But she is complaining, ma'am. But that she is having little bit of pain, not that much of severe. But initially, when she presented, that time the patient is complaining that pain is too much of severe in intensity. So,
Hypokalemic
But
paralysis,
there is no past history of similar episodes. Hypokalemic periodic paralysis is usually a recurrent issue. So in the absence of past history, it's not coming.
Yes, that's fine. That is the point.
okay, sir. Sir, Third is transverse myelitis because that will also present as a sudden onset bilateral lower limb weakness, sensory disturbances, and back pain. But in this patient, there is no back pain history, only pain in bilateral lower limb. And fourth is paired, ma'am.
Back pain is usually not a very prominent feature of transverse myelitis.
Yes.
and have you mentioned about sensory complaints in the history?
Uh,
And in history also you can ask the patient about the sensations.
In
There
range
is a
number.
paralysis, okay, but on history you ask about the. Is it like in on history also you can find out if the patient has sensory involvement or not? Motor weakness you have explained, it has gone from distal
Distal
to
proximal.
But have you asked about the patient sensory involvement?
No,
From a
ma'am.
negative history perspective, were you able to feel your growth? Were you
Yes.
able to feel the
Feel
blanket
the
over
blanket.
your body?
Yes.
Bladder power में पूछना है, sensory पूछना है. You have to ask me.
Yes. And
So many glands.
yes. Fourth one is compressive myelopathy. So we're thinking that for spinal cord compression due to structure abnormalities or such as disc herniation, or there is a port spine tumor or vascular malformation would present similarly.
What are the features which are against this point in your history?
Uh,
Compressive.
Sir, there is a no bladder and bowel involvement. First point. So second is
Asymmetrical presentation.
yes, yes,
And there is no pain.
pain.
Compressive myelopathy would present to pain followed by weakness.
Particular pain.
So general physical examination.
Presentation is this presentation I say almost let's say having lower the background history of some those who thought we are in the last 19 back. What else we can thought? We have thought this much.
The differential diagnosis are okay, but you should know the positive and the negative.
Right.
So it's general physical examination. Patient is conscious, oriented to time, place, and person, comfortable and cooperative. Average build. There is a no pallor was absent, icterus was absent, cyanosis, clubbing, lymphadenopathy, and pediledema is also absent. There is no scar, burns, or decubital ulcer or tropic ulcers. She is a right-handed individual. There is a no neurocutaneous markers positive. Vitals are pulse rate 89 beats per minute, taken in right radial artery, normal rhythm, normovolumic, and no radial or radiofemoral delay, and no pulse deficit. Blood pressure was 118/68 mm of Hg, taken in right arm in supine position, and respiratory rate is 16 per minute, regular and thoraco-abdominal type. Temperature was afebrile, measured in axilla, and SpO2 is 99% on room air. There is ma'am, low hypotension in case of autonomic yes, posture. Better.
Vital example.
Resting tachycardia. That is not there. There is a no in CVS S1 S2 present. There is a no murmur and respiratory bilateral chest clear, and per abdomen there is a no tenderness, soft and bowel sounds present. Now, ma'am,
Not that there is no respiratory involvement as such in your history also.
yes.
But in examination, what else? What is single breath count? Can it help? Will it help in our listening? Single breath. Early respiratory involvement. Started.
So now neurological examination, higher mental function, patient is conscious, oriented to time, place, and person, speech, language, and memory is intact. There is a no delusion or hallucination, and MMSE score is 28 out of 30. There is a no signs of meningeal irritation. All cranial nerves are intact. In motor system examination, bulk of the muscles bilateral normal. Tone in bilateral lower limb, there is a flaccid type, and power is 1/5 on the presentation. In the right in bilateral upper limb, there is a power 5/5, and the reflexes, superficial reflexes, corneal reflex present, conjunctival reflex present, pharyngeal present, palatal present, abdominal present, cremastic reflex also present, and perianal reflex also present, and plantars are bilateral flexor, and deep tendon reflexes all are absent. Yes, ma'am. Yes, ma'am. And ma'am, cranial nerve examination, all cranial nerves are intact. There is no any abnormality found. Coordination, upper limb, finger, nose, taste, drawing of circle, that is all are intact. Upper limb, lower limb, knee heel test and drawing a circle. Actually,
In
yes,
the presence of so much weakness, you cannot test coordination.
sir. It is one. Actually, sir, on presentation it was 1/5. After giving therapy, sir, it was improved.
The day when you have examined might be that that is lower in coordination you have checked. Then you have to tell that on the day of examination what was the power. That 1/5 was on
Presentation.
And on the day of examination when you have examined, then you have to tell that.
Ma'am, this was actually 1/5. In patient was present in OPD, so we have examined in OPD itself. So that was
Coordination then is.
okay. So, gait is a waddling type, means to walk with short steps and rocking from side. Sir, actually, sir, she is telling sir that he is moving with his mother with support, with side by side with support. Ma'am, this was after.
What are the joints? Joints are for ankle power, knee power, hip power.
How you have graded it 1/5? What do you mean by that 1/5?
Ma'am, she is not able to flex even without. Yes.
Section of that kind. What is 1/5?
Ma'am, just flickering a moment.
Just flickering. Huh?
Flickering.
So 1/5 is flickering. When we are taking just flickering, how we expect her to stand and walk. So it is not 1/5. If at all she is standing, then it is not 1/5. Three हो गया ना? Three and also.
Yes. So there is no involuntary movements. Sensory system in spinothalamic tract, crude touch, pain, and temperature is lost. And posterior column, there is a loss of only fine touch. Vibration and position sense is normal, and Romberg signs could not be assessed. Cortical pathway discrimination, tactile localization is also normal. Autonomic nervous system. Sir, below bilateral flanks and in bilateral, sorry, below lower abdomen, sir. Sir, ma'am, actually, yes, sir. Lower limb.
Say that temperature, you said temperature sensation is lost.
Yes, ma'am.
How you example, how you check?
Ma'am,
Because in your history, you have not mentioned anything regarding this. So in history also. But all this temperature loss. It's hot and cold, you want to say.
yes, ma'am.
Sensory level बताना पड़ेगा. Yes,
The hot and cold sensation. Hot and cold sensation only I want to tell in this.
sensory level तो बताना पड़ेगा ना अभी.
That was abdominal reflex is present, sir. Yes, ma'am. Sorry, ma'am. In upper, below, above umbilicus, it was present. Below the level of umbilicus, it was absent totally. So below the ma'am bilateral flanks and below it nahi hai, ma'am. There is ma'am L. No, sir. It was thoracic. T. D10. D10.
I think it is the first time he is presenting that first line of the second. This art. I think carry on next, yes. He's doing right. Bombard them so much questions. Probably they will, yeah, not come forward in the future. Please carry on. You are doing very well. Good.
No, ma'am.
Yes. It is a learning process. You are learning from this. Please carry on. You are doing good.
Sir, autonomic nervous system, there is no bladder or bowel incontinence, no palpitations, no sweating disturbances or early morning stiffness.
You said there was no bowel involvement earlier.
Yes, sir, there is actually no bladder or bowel incontinence. I have forgot to mention no, sir. Yes, sir. Yes, sir. It was not there, sir. So there is no abnormal muscle movement. There is no athetosis, no chorea, no hemibellismus, or no numbness, tingling, pricking sensation, and there is a loss of hot and cold sensation in bilateral lower limb. And in autonomic nervous system, there is no postural hypotension, no resting tachycardia, no abnormal sweating. There is meningeal signs are already absent. Examination of the spine and cranium, there is a straightening of spine, but there is no tenderness or no bony abnormalities. And ma'am, actually,
whatever you have written, what you have thought of, you just tell that.
What do you mean by straightening of the spine? What you want to convey by this? Straightening of the spine का क्या मतलब है?
sir, Sir, there is no peripheral nerve thickening or tropic ulcer or wrist drop. Sir, on investigations, CBC hemoglobin was 12.9, platelet was 2.92, RBC was 4.45, TLC count is 7350, KFT urea is 49, creatinine is 0.65, uric acid is 4.60, calcium is 8.99, phosphorus is 4.64, sodium is 138.5, potassium is 4.20, protein is 7.02. And LFT was total bilirubin was 0.62, SGOT is 31, SGPT was 30, ALP 158, albumin is 3.80, globulin was 3.22, and GGTP was 28. On CSF analysis, we have performed after 2 days of admission, which was appears normal. Cytology and biochemistry, glucose is 60, protein is 35.80, color is pale white, appearance is clear, coagulum is absent, and WBC is 4. And DLC differential count was neutrophil 0, lymphocyte 100%, and LDH is 70, and DA was 5.9. So now ultrasound of the whole abdomen was performed on 14th. So it was shows multiple enlarged hypoechoic mesenteric lymph nodes with loss of fatty hilum and surrounding echogenic inflamed mesentery Few of them shows conglomeration and necrosis. Largest measure 28 into 13 mm. Minimal amount of free fluid noted in peritoneal cavity, and impression was mild hepatomegaly with grade 1 fatty liver, mild splenomegaly, abdominal lymphadenopathy, and mild ascites. Now, we have gone through CMRI of dorsolumbar spine with whole spine screening. So dorsal spine and lumbar sacral spine is normal. On contrast MRI, there is a small ring enhancing lesion to contrast at the level of L1 cord level. Appreciated on axial Gado sequence and sagittal contrast MRI at the same level. And screening of whole spine, there is cervical spine is straightened with insignificant disc bulge noted at C4 to C5 and C5 to C6 level. And impression was made of possibility of intramedullary tuberculoma as a known case of abdominal tuberculosis. So this is the image which is showing red arrow mark is showing tuberculoma. Actually, the lesion is not perfectly with perilesional edema because patient was already taken ATT prior 1.5 years ago. And so according to she stopped on her own. Yes. 6 months sir, she was taken and then she left. And sir, so final diagnosis on the basis of my patient, 20-year-old female, is most probably a case of acute onset flaccid paralysis with sensory involvement due to compressive myelopathy, which was cause was intramedullary tuberculoma at L1 level with TB lymphadenitis. Ma'am, ma'am, intramedullary. Ma'am,
Extradural, intradural, extramedullary, and intramedullary.
But initially what we heard, we are dealing with some people at it, maybe but this surprisingly this time like this that is the on university also has complicated abdominal sort of equipment and evaluation because of possibility of dance and vessel there. That's what we have decided to arrive and we have given steroid capability to I think the effect of steroid because very dramatically improved. We can say dramatically improved. Within 2 days, I think 4 by 5 hours, and she was continuing walking and doing continuing and this was my guidance. That many other your side, sir.
Intermediate tuberculoma are known to us, but they are not the very common presentation of venous tuberculosis. So did we try to obtain a tissue diagnosis from the lymph nodes or ascitic fluid?
That's what I'm telling you. It was very documented and everything that was but because I think the very secure that
worthwhile to obtain a tissue diagnosis. You can't do that from the spine, but from the extra CNS tissues we can do that. Any acute myelitis, deep complexes can be absent in the acute stage, but because the spinal shock. But later on, they would become exaggerated.
So, any further follow-up observations?
Sir, actually, sir, we have patient is in sir not affordable. So, and the second thing, sir, I have called one two time, but walking state, sir. Yes, ma'am, I have called, but she didn't pick up, ma'am.
Is pretty this looks pretty symmetric. If there is a compressive. If it is a process malleable, then it is a different thing. Breast phase and bleeding. Again, it is pretty.
Yeah, our investigation for area whether now, but that's what
Diploma is pretty uncommon.
Yes, ma'am. No, ma'am. Actually, we have not done because of cost issue. Ma'am, she was under. Yes, ma'am. Same as.
Thank you, Dr. Jay. It was nice presentation with few discrepancies, so we should work on it.
Yes, ma'am.
And we should see whatever complaint or whatever thing you have in writing or you are presenting, you should be able to justify with your case. And you should be able to explain or interpret what you want to tell.
for your exams.
Yes, for your exams. And otherwise presentation also. Thank you, sir.
Thank you, ma'am.
Thank you. Ma'am, please. Thank you, Nika. I request Dr. N.K. Govind to kindly come over the stage to felicitate the presenter, moderator, and the chairperson. Dr. Jay, please. Ashok, sir. So our next presentation is an unusual manifestation of acute viral hepatitis. I request Dr. Divya Darpan, third year DNB resident Max Vaishali, to come over for the presentation. The case is going to be moderated by Dr. Vandana Garg, senior consultant physician Max Vaishali, and Dr. Namita Kauls, consultant neurologist Max Vaishali, is going to chair the case. I think we have another chairperson, Dr. Pavitra Sahu, I think is not available. I request Dr. Divya to kindly start with the presentation.
Good afternoon, everyone. This is our present a case of viral hepatitis. It came with the routine viral hepatitis and gave us a very unusual presentation. Over to Devendra.
मैंने आपको भेज दिया भेजा है मैंने Good afternoon, everyone. So today I'm going to present an unusual manifestation of acute viral hepatitis. So basically, my patient Nikita Bhandari, female, 26 years, and resident of Sector 5 Vaishali, working in an MNC, presented to Max Vaishali on 7th June 2024 in morning with complaints of high-grade fever, multiple episodes of vomiting, abdominal pain, which were all since 2 days. So first of all, I want to give a disclaimer that we have taken proper consent from the patient, as we have added few videos of the patient for academic purpose. So past history, there was a past history of right-sided pneumonitis for which patient was admitted in Pushpanjali Hospital at the age of 16 years and was empirically treated as pulmonary cox. So this is the HRCT of the patient at the age of 16 years, and she was admitted and worked up and she was given empirical ATT. Now, coming to the reports, on day 0, her counts were normal, and CRP was 39. Her paired blood culture was sterile, and urine culture revealed Enterococcus faecium. Her ultrasound was within normal limits and her SGOT, SGPT was 438 and 290. Patient was not clinically icteric on day 0. Then day 1 to day 2, patient's hepatitis A virus IgM came out to be positive. So, and on this day only, patient clinically became icteric. HEV IgM was negative. Repeat LFT was done on day 2, and it came out to be SGOT was 1384 and SGPT was 984. Her bilirubin levels were 2.3, direct was 2.1. Her INR came out to be 1.44, for which she was started on vitamin K injection. Her ALP and GGTP were 134 and 244 respectively. There were no clinical signs of encephalopathy. Patient had burning micturition, which was attributed to the urine culture and UTI. What's up? No, sir, she was not alcoholic. On day 3 and 4, patient's oral intake gradually decreased. Her vomitings increased in frequency and intensity, and she was not able to take orally. Her, as expected in the case of viral hepatitis, her bilirubin counts, bilirubin levels increased, and her SGOT, SGPT levels also increased to 3000 and 2000. On day 5, she was having persistent vomitings and her oral intake further decreased. Her CRP increased from the initial value of 39 to 70. And as expected, her SGOT, SGPT were rising as it happens in viral hepatitis, and alkaline phosphatase was 132. Then in the evening of day 5, a gastroenterology reference was done in view of persistent vomitings, and patient was having severe epigastric tenderness, and she was not able to take anything orally. The gastroenterology team advised to start the patient on PPI infusion along with NAC, glutathione, and Heptral, and send amylase lipase to rule out cholecystitis/pancreatitis, and advised a repeat ultrasound. In view of persistent vomitings, she was advised injection perinom 1 ampule IV stat, as her vomitings were not getting controlled with MSET 4 mg IV TDS. Following perinom injection, patient developed a opsoclonus in both eyes along with flapping tremors. Query EPS. On day 5, she was shifted to the ICU. Day 6 in the ICU, this is the video. Day 6 in the ICU, the opsoclonus and the myoclonus persisted. Patient was drowsy and dull. The repeat ultrasound, as suggested by the gastroenterologist, revealed query hepatomegaly and query diffuse GB wall edema. In view of persistent opsoclonus myoclonus, neurology reference was done, and she was advised electroencephalography and MRI brain. Both were within normal limits. Patient was given Phenargan 25 mg TDS along with Pacitane 2 mg TDS, but satisfactory response to Phenargan was not observed. We were thinking on the lines of extrapyramidal side effect of uh, perinorm, but if it would have been an extrapyramidal side effect due to perinorm, it would have subsided with anticholinergic drugs like phenargin and pacitane, that is trihexyphenidyl. Patient was worked up for Wilson's disease. In the ICU, her counts increased to 30,000 and her antibiotics were modified as per urine culture reports to linezolid and tazact. Day 7 in the ICU, the opsoclonus myoclonus improved minimally. Lumbar puncture was planned to find out the cause of the opsoclonus. Postural tremors were present. Ophthalmology reference was done for opsoclonus along with slit lamp examination to rule out any KF rings for Wilson's evaluation. On day 7th in the ICU, her SGOT, SGPT started improving. Bilirubin kept on increasing. It was 3.7 and TLC gradually improved. So her previous day count of 30,000 were considered reactionary and her antibiotics were de-escalated. Her ammonia was found to be 144 and hyperammonemia measures like laxatives, rifaximin were given. Phenargin was gradually tapered off, although the opsoclonus myoclonus component and the tremulousness still persisted. In view of the Wilson's disease, copper 24-hour urine came out to be negative and ceruloplasmin was within normal limits. ANA and vasculitis spinal, there was nothing significant. ANA and vasculitis spinal were negative. Her CSF reports were within normal limits. Her CSF glucose was 62.4 mg per deciliter. Her protein was 18.1. There were 5 lymphocytes and her ADA was negative. Since there is an autoimmune involvement in a lot of cases of opsoclonus myoclonus, we considered steroids. But in view of active infection, that is UTI, it was withheld. Day 9 onwards in the ward, the opsoclonus kept on decreasing daily minimally. Patient's appetite improved slowly. Phenargin and pacitane, that is trihexyphenidyl, were tapered gradually. Patient then complained of vertigo on standing. So the patient was evaluated for orthostatic hypotension and she was found to not have any component of orthostatic hypotension. Her repeat MRI brain was done in view of persistent opsoclonus myoclonus and persistent tremulousness, which was also within normal limits. Now, her SGOT, SGPT decreased to 161, 295 at the time of discharge. Bilirubin gradually increased over the course of stay, and on the day of discharge, it was 7. Then towards the discharge, LFTs revealed a cholestatic picture, which was likely due to hepatitis A. Physiotherapy was also done in view of the ataxic gait and tremulousness for 4 days, and the diet gradually improved. But the opsoclonus persisted but improved gradually with each day. Patient was discharged on the 14th day of admission as a case of complicated viral hepatitis with grade 1 hepatic encephalopathy with pendular nystagmus secondary to hepatitis A. So provisional diagnosis is of opsoclonus myoclonus syndrome, which could be explained secondary to either hepatitis A virus or second drug-induced. Oh, Shambhuji.
This SGOT was much more than the SGPT.
Yes.
Was there what do you expect in an acute viral hepatitis? In acute viral hepatitis, SGPT is limited than SGOT, but there is no hard fast rule. Sometimes there are some mitochondrial damage that requires. In those cases, SGOT become more than SGPT.
And in some literature, it is one of the poor prognostic marker. SGOT remains elevated and SGPT decreases more than SGOT. It remains a poor prognostic marker. It indicates extensive hepatocyte damage. It is not necessarily every viral hepatitis SGPT will be more than SGOT, but it is generally the norm. And if SGOT is more than SGPT, there are extensive necrosis and mitochondrial damage which recovers later. So SGOT persistently elevated and SGPT falls. That is why it seems like SGOT more than SGPT.
The ultrasound initially was normal. Yes, and GBD and hepatomegaly. Yeah.
But hepatitis A and it was day 3 when it was 1.2.
What kind of level we should give it down here?
So there are some things that if we go by literature and go very scientifically, there is no role of vitamin K in any INR in acute hepatitis. Even in liver failure, there is no role of vitamin K. But we all give vitamin K varying our threshold. We all give vitamin K. We think that will improve, but scientifically there is no data to support the vitamin K even in INR 3. It doesn't help. Nothing. There is no cutoff. There is no recommendation for giving vitamin K, FFP, prothrombin concentrate, any type of coagulation factor in acute viral hepatitis or acute liver failure. The major disadvantage is that now, suppose this patient went into hepatic coma, grade 2-3 hepatic encephalopathy, then liver transplant comes in picture. So, should we go for transplant or not? So, we should not give anything that falsely normalize the INR. Because INR just is a value. We are seeing the liver cell is necrosed and liver is not recovering. So, we only things we can monitor is not SGOT, SGPT. SGOT, SGPT is not prognostic marker. The only thing biochemical marker we monitor is INR apart from the encephalopathy part. So we should not give anything that falsely normalize INR. That is the practice. That is the scientific practice. But we all practice. We give vitamin K. So if INR persistently increase, it means liver is not recovering. Hepatocyte is necrosed, then transplant surgeons should come in picture rather than falsely normalizing INR, giving vitamin K, giving FFP. It will not help. It has a very short half-life. It will not help.
This case, as the neurological manifestation was abruptly noticed after the injection of metoclopramide, which we know has extrapyramidal side effects. Although it's a rare phenomenon, opsoclonus, but drug-induced opsoclonus is very well known. The hallmark is that it improves very rapidly. So once we give injectable phenargin, which reverses the opposite effect and it helps in improving and the patient will. But in this case, it did not. So that's what our final diagnosis was towards, that it was a opsoclonus myoclonus syndrome. 50% of the patients are paraneoplastic, but in this case, it was a para-infectious associated with the hepatitis A virus infection. No, so we have to see the syndrome in total. It was, as clinically we can see, the hallmark, it was a dancing eye, dancing feet syndrome. That's what the other name for opsoclonus myoclonus is. The eye movements is typically opsoclonus, and there was a truncal ataxia. She was unable to walk. She had tremulousness. So it was not a flapping tremor. Hepatic encephalopathy, that is a negative myoclonus, the flapping tremor. It was a myoclonic tremor. Was that thing? So the semiology was not that of a negative myoclonus. It's not a nystagmus as well as, it's not regular nystagmus. Such chaotic eye movements as you can see, dancing eyes, that's why the name is. But it's always conjugate. It's, yeah, they're moving together, but in all directions. Can be present even in sleep. So when she closes her eyes, we could appreciate at that time also. The opsoclonus is typically present when the eyes are closed as well, and which we noticed in this. The nystagmus will not remain with eyes closed.
Yeah, initial medication you gave him.
Not mention the earlier antibiotic. You said change it to rheumatologic.
Yes. Initially it was, we started with cephalosporin. And monoceph. Yes. So this is the latest video post the discharge. So basically, we tried finding out review of literature for this. So in Journal of Child Neurology, there was a journal with impact factor of 2, basically infection associated opsoclonus, a retrospective case record analysis and review of literature. So in this, basically opsoclonus is an uncommon clinical sign and is often described in the context of opsoclonus myoclonus ataxia syndrome. It may be both paraneoplastic or post-infectious. However, opsoclonus with or without opsoclonus myoclonia ataxia syndrome may occur in association with a wide gamut of infections. Infection-associated opsoclonus needs recognition as a separate entity since it demands relatively brief immunosuppression, symptomatic treatment, and has a better outcome. They are also able to find one article which showed virus-induced central positional nystagmus, which was observed in mice. So basically in this, nystagmus was observed in a 4-week-old mice after intracerebral injection with a temperature-sensitive mutant of mouse hepatitis virus. But in our case, we did not find nystagmus, we found opsoclonus myoclonus. So a brief about opsoclonus myoclonus syndrome. Basically, it is a rare disorder that affects the nervous system. The symptoms include rapid multiple directional movements, which is opsoclonus, then quick involuntary muscle jerks, uncoordinated muscle jerks, uncoordinated movement, and irritability and sleep disturbance. The disease may become chronic. And these are some of the causes of opsoclonus myoclonus. It can be idiopathic, then it can be paraneoplastic, secondary to lung cancer, breast cancer, or the classical neuroblastoma seen in children. Then it can also happen with autoimmune encephalitis, like anti-NMDA receptor antibody positive. Then it can happen post-infections like COVID-19, hepatitis C virus, HIV infection, mycoplasma pneumonia, human herpes virus 6. Thank you.
So this was a very interesting case. We're unable to find review literature opsoclonus myoclonus with the hepatitis A infection. Other viruses, para-infectious opsoclonus myoclonus, anyways, is a rare entity. Paraneoplastic is the most common. Post-infectious is also the second common, and then para-infectious associated. The management usually is that you manage for a para-infectious. It is an immune-mediated phenomena most of the times, and some kind of immunosuppressant is always required. First, our giving phenomenon was to decide whether, if it is drug induced, then it will reverse and then in a few days it goes away. But for otherwise, the typical opsoclonus myoclonus is immune mediated, and we need to, whether it is paraneoplastic, post-infectious, para-infectious, we need to give immune suppressants. In a para-infectious situation becomes a little difficult because my gastroenterologists were skeptical about giving. I said, let's give steroids, but they were a little skeptical about giving steroids in her because it was also fulminant hepatitis. So we decided to wait. It was very rapid onset, but overall, within, she started improving fast. First week was very debilitating for her, but subsequently, and since we did the CSF and acute encephalitis was also ruled out, so we decided to hold on to the steroids. That was one thing we did. Otherwise, generally steroids are always, or IVIG are recommended to be given in the case of obstetrics. Thank you. Yes, he gave you a list. It's rare. Drug-induced opsoclonus is also known. Some SSRIs, SNRIs are known. Phenytoin is known to cause. He gave you a list. There are a few drugs, but less known. So it is the pathology is the pontine in the brainstem area. The circuits are affected there. So at multiple levels, the neurons affected, and that's what causes the. So infectious is during the infection. Post-infection is now the infection is over and then.
Thank you, Dr. Divya. Dr. Divya, please stay back. I request Dr. Lalit to come out to the stage for felicitation. Felicitate. Now I request Dr. Pankaj to kindly come over to announce the EDPA Champion Award for this.
So thank you very much. I think you must agree that these are very interesting cases. I think first one, paraparesis, we all see and how to approach these patients. And second one, definitely it's the rarest of rare case. In fact, we are just finding the literature because I also had a word with Dr. Vandana that you should present this case because we don't see these cases, often. So I think we should come out with these interesting cases which are very interesting, which are quite rare, so that at least पता लगे कि actually ये चीज होती है, right? हमारे पास कभी कभी आते हैं केसेस, इंटरेस्टिंग केसेस, बट सम हम लोग छोड़ते हैं क्या है, मतलब नहीं करते प्रेजेंट. बट आई थिंक दिस इज अ फोरम दैट वी कैन डिस्कस ऑल दिस केसेस. चाहे वर्क अप हो चाहे वर्क अप ना भी हो, तभी एटलीस्ट वी शुड कम अप टू प्रेजेंट दिस केसेस. तो मैंने आज ग्रुप में डाला है कि कोई इंटरेस्टिंग केसेस हैं तो हमें बता दें एडवांस में, सो दैट वी विल हेल्प यू टू प्रेजेंट ऑल्सो, विल हेल्प टू द पेपर स्लाइड्स. हम लोग काफी रेजिडेंट जेल रेजिडेंट्स हैं, वो चाहते हैं कि हम कुछ केस मिले उनको प्रेजेंट करें, उनको बनाए स्लाइड्स. तो आई थिंक अगर आपका कोई केस है जो लग रहा है कि हम कर सकते हैं प्रेजेंट, तो कम ओवर विल प्रेजेंट द केस, राइट. तो जब से हम लोगों ने टेक ओवर किया है, मैंने और स्वाति ने, तो हमने बोला कि हम लोग जैसे लास्ट ईयर हम देते थे, हर साल अवार्ड देते थे सर, नॉमिनेशन लेते थे, तो क्यों नहीं हम लोग मंथ में एक बार करें, क्योंकि हम लोग बहुत अच्छा काम कर रहे हैं सर. वी आर डूइंग लॉट ऑफ गुड थिंग्स एंड वी शुड प्रेजेंट नॉट ईयरली, वी शुड प्रेजेंट मंथली. तो एक हमने एक इनोवेटिव आइडिया लिया है कि जो लोग अच्छा काम कर रहे हैं, या हम उनको पहुंचेंगे या वो हमारे पास पहुंच सकते हैं कि देखो मैं अच्छा काम कर रहा हूँ, मुझे अवार्ड दे दो, राइट. तो दिस कैन बी डे इधर वे आल्सो, दैट इफ यू आर डूइंग गुड वर्क, डेफिनेटली विद द वी शुड आल्सो नो दैट वी आर डूइंग गुड for society in the academics front, whatever the front that we are doing good work. So इस बार हमने चुना है डॉक्टर निर्मला लाहौटी को. I think she's there. I think we should give a good round of applause to डॉक्टर निर्मला लाहौटी. तो ऐसे हम मिल गए थे, बात करते हैं, मतलब कि तो मैंने बोला कि हम लोग ये सब काम कर रहे हैं फ्री ऑफ कॉस्ट सोसाइटी, जो एक हमारी एक सोसाइटी है, हमारी पाकिस्तान मूवमेंट डिसऑर्डर की सोसाइटी है. So she is doing God good of work, and I request Dr. Nimla to tell us about this thing that we'll proceed afterwards. Dr. Nimla, ma'am.
Evening, everyone. Warm welcome to you all. And first of all, I would like to thank Dr. Pankaj Chaudhary to give me an opportunity to introduce PDMDS to this gathering. PDMDS is Parkinson's Disease and Movement Disorder Society, based in Mumbai. And the motto of the society is to improve the quality of life for people with Parkinson's and their families. I'll just play a small video of what we have been doing here. PDMDS, as I mentioned, is Parkinson's Disease and Movement Disorder Society. The founder of this PDMDS is Dr. Padamshri Dr. B.S. Singhal. He's a very senior neurologist in Bombay Hospital. He had registered this society in 2001, and initially it was just started with one single community center. Now they have almost total around 70 centers all over India. Parkinson's disease movement disorder, it's an all India charitable society for improving the quality of life of people with Parkinson's and their caregivers. Objectives are to raise awareness about Parkinson's and other neurological conditions like other movement disorders, to provide free therapy to people with Parkinson's, to promote healthy living. As we all know that Parkinson's is a lifelong condition with it has a range of symptoms. They have challenges in their day-to-day activities. They have tremors, which they have difficulty holding a spoon or feeding themselves, difficulty in walking. They also have other non-motor symptoms. The PDMDS model of care provides access to support, and rehabilitate patients with Parkinson's and also their caregivers. What is the PDMDS model of care? It's a multidisciplinary model in which they educate about the disease, then the strategies for effective management of symptoms, and its community-based setting. Benefits of this group therapy is that you realize you are not the only one with Parkinson's, interact with people who have Parkinson's and make friends, share your experience with others and learn from them, get motivation and support from others in the group, and enjoy exercising together. It's a physiotherapy based treatment to improve movement and independence in activities of daily living, to maintain the posture, balance, hand movements. Here, some aerobic exercises are being done, band exercises, mat exercises. These are all PD specific exercises. This is a Thai, which is martial art, which increases the strength and also maintains the posture. Voice and movement integrated therapy is being given, and boxing also is being done. There is other PD specific exercise like functional training. They are trained how to walk without to prevent fall, then how to come out or sit in a vehicle, then like here how to take a round, they have a tendency to fall when they take a U-turn. So this they train them how to take a U-turn with a wider range. All these gait training are being done. Speech therapy is also very important to increase the volume of the voice for clarity of the speech. They do breathing exercises, and also they are trained to improve their facial expressions, and also swallowing process, which is impaired in these patients, are being they are being trained for that. This improves the communication. Counseling and psychotherapy is also being done. The emotional and the psychological needs of the patient and his family too, to work on social stigma, anger, depression, anxiety. Cognitive therapy is also being given strategies to optimize memory, attention, problem solving, decision making, plan and organize. So they have different tools every time to give these kind of therapy. Art therapy also improves eye and hand coordination, fine motor skills, cognition, mood, reduces anxiety and depression in Parkinson's disease patients. It's creative and also improves the emotional expression. That also is very, very important in PD patients. Timing of food, type of food, medications, timing of food with the medication, managing constipation in Parkinson's disease. So these are the some foods which they are advocated to take. Dance therapy is very, very popular in this group. It breaks sense of personal limitation and boundaries, provides temporary symptomatic relief through shifting focus from the symptoms into the activity. So these are the multidisciplinary model of care: physical exercise, education on Parkinson's, exercise to improve speech and communication, cognitive activities, art and craft activities, diet and nutrition, dance and movement. All these are being taken care in our PDMDS rehabilitation therapy centers. They have weekly multidisciplinary group video call sessions also for physical exercise, speech therapy, cognitive therapy, and creative therapies. And the psychoeducation about monthly, they have sessions for caregivers for psychoeducation about PD symptoms management and strategies to help people with Parkinson's with various ADLs. Tips to manage caregiver burden, discussion on the psychological impact of the pandemic on caregivers, building a support network among caregivers too. So in East Delhi, here itself in IMA, we are having these sessions on first and third Sunday of the month at 10 a.m. for almost 1 to 1.5 hours. And the next Sunday is on 21st July at 10 a.m. So I hope I request you all to please send your PD patients to take benefit from this NGO's work. And it is all free of cost.
Thank you, ma'am, for taking initiative. And I think there are someone that were taking care of societies, and I could see that improvement also on the faces. They are quite happy dancing, you know. So I think this is a very important aspect of every disease, right? Be it Parkinson's, be it every disease. The rehab is also very important. We are all treating the patients, but we just forget about rehabilitation, right? Rehab in the neuro care, rehab in the pulmo care, right? So thank you, doctor, for giving us the right a thought that actually we should also take care of those patients, definitely. So to President Nimla Lordy, I would like to call upon Dr. Chaturvedi sir, who is the senior most here, and very enthusiastic, and he attends all the monthly meetings. I think we should learn from him. And Deepa Lordy sir, you are also welcome.
For that, I must congratulate the government and commend the president, new president of the EDPA, Dr. Pankaj Chaudhary. See, what is new? A leader is one who brings something new, who initiates, inspires, and involves himself. He has started this new thing by honoring or giving recognition to the people who are doing something new. But so something new to the society. And Dr. Nirmal Lahoti and Dr. Deepak, I know them. They're under postgrad days when they started carrying IMA in East Delhi, 1989, probably, Deepak Hospital. And she has done a commendable job. Social neurology is very important aspect. We all do clinical part, but you do something for the society, for the betterment of people, which is a great thing. Where is Madam? Nari I request we have this two great ladies, Dr. Tom and Dr. Garg, and we are honoring Nari.
Please join us.
Vijayalakshmi. And for them, I can only say to Nirmal Lahoti before I present her. नारी तुम केवल श्रद्धा हो, नारी तुम केवल श्रद्धा हो, विश्वास रजत नग पत्तल में और सोच की बाहर हो मन के सुंदर। After Deepak, it is your, unless you get the inspiration from a person like him,